Welcome to Body in Balance Podcast. I am your host, Charlotte Johnson, the certified licensed physician assistant, sent here to kick some knowledge your way once a week for the purpose of educating, informing, and enlightening this audience concerning physical, spiritual, and emotional aspects of our bodies in relation to our Creator, the one, the only, the true and living God. He is the King of Kings and the Lord of Lords. Let us give it up for Yahweh. Hello, once again. We are going to be talking about the ear, the human ear, and this is season 3, episode 2, and we're going to be talking about something real hot and heavy, and that is vertigo. Vertigo or dizziness. Help, I am spinning out of control. Understanding and managing the sensation of dizziness or vertigo. Now, that term is used, and it's one of my pet peeves. It's used very generally. Everything is vertigo and everything is dizziness when it comes to somebody being off balance or feeling like they're going to pass out. If you feel like you're going to pass out or you feel lightheaded, that's not vertigo. If you feel like you're staggering around and falling all over, then it needs to be determined, is it vertigo, dizziness, or is it something called ataxia? That's a problem that's neurological. So just using the term dizzy is similar to saying, wow, those are some really nice jeans. Well, what kind of jeans are they? Are they Wrangler jeans, Levi jeans, Lee jeans, Vanderbilt jeans, Chick jeans, Arizona jeans? You get my point. What kind of vertigo is it? Well, this is what this episode is going to be discussing. Why? Because, like I said, it's a pet peeve of mine being an otolaryngology PA, where it's like everybody sends anything that has anything to do remotely with somebody feeling like they're going to pass out or fall over or they stagger around. They say it's dizziness, and that's not necessarily true. A lot of times people go to the ER so they can make sure they're not having a stroke. Once the ER finds out it's not a stroke, that's as far as they go with it. Off you go to ENT, because ENT is fairly easy to get into for follow-up. And so that's how you end up with us. So let's get started, because we've got a heavy agenda. The agenda items are, we're going to get an understanding. The Bible says, in all thy getting, get an understanding. We're going to get an understanding of vertigo, but we're going to get an understanding of what's vertigo that has to do with the ear. Understanding vertigo, there's 5 things when my patients come to me that I'm going to try to analyze, scrutinize, evaluate, and try to determine, is it one of these 5 different items? If it's not, then you're dizzy, and your dizziness or your lightheadedness has nothing to do with your ears. Everybody says Every type of dizziness has to do with these crystals that are in the ear. We're going to talk about that. 90% of dizziness that has to do with the ear is covered under benign paroxysmal positional vertigo, BPPV. I left out a P, but it's benign positional vertigo. Benign paroxysmal positional vertigo is 90% of the cause of most dizziness if I say that with an asterisk, if it is ear problem dizziness. The second cause is usually something called labyrinthitis or vestibular neuritis. I should have put those in a different order, but we're going to talk about it this way: labyrinthitis or vestibular neuritis. Labyrinthitis has to do with that snail-looking organ that I talked to you about in our first episode, which is the cochlea. You can get an infection, a viral infection in the cochlea. You can have a severe cold. Now, with labyrinthitis and vestibular neuritis, you are very, very sick. Very sick. Head cold, like you have a sinus infection, or there's nasal congestion, you're coughing, you're running a fever, you feel horrible. And not only do you feel horrible, but you're spinning. I mean, spinning. Because dizziness for ears, most times it's room spinning. And someone who's an otolaryngologist is going to want to determine, are you having room spinning, floor moving type sensation, or do you feel like you're going to pass out or you're lightheaded? That's not ear dizziness. If you say that you've had syncope, what in the world is syncope? Oh man, I'm glad you asked me. Syncope is when you literally pass out. You black out. That is not ear dizziness. Ear dizziness never makes a person pass out. That's not ear dizziness. It's something circulatory. It's cardiac. It's something other than ears. So, labyrinthitis, you will have, or vestibular neuritis, you will have quite a bit of dizziness, so bad you can't stand. You almost have to crawl on all fours. The reason why is your body has no spatial concept, no spatial or spatial awareness. So you have to be on all fours to know, so that you feel like you're not going to fall unless there's somebody there with you. So if you are so sick, vomiting, nausea, having to crawl around, can't get up because you're so disoriented, that's either labyrinthitis or vestibular neuritis. That lasts anywhere from 2 to 3, sometimes 4 weeks. Now, during that time, the first 3 to 4 days of that is really bad. But over that 3 to 4 week, you gradually start to get better. However, if you get a terrible insult or injury to the nerve or to the cochlea, you can have some lasting effects. And I'll talk to you about what we need to do about that. The next thing there is something called Meniere's disease. No one knows why people get Meniere's, or they don't really have a full understanding of how it comes about. They do know some things that trigger it. High sodium diets, excessive alcohol, and poor amount of drinking fluids like water, high caffeine intake. Those things tend to trigger Meniere's disease. The next one is extremely rare, but this also has to do with the cochlea. The cochlea is that snail-looking bone, and it had those loops. The loops that you saw on the screen when I showed it to you in the imaging, those loops can sometimes, that's bone. And if that bone wears away, then there's fluid inside that cochlea. We talked about that. And that will leak out. And when it does, usually high, quick, frequent noises can trigger you to be dizzy. I had a patient that he was standing on the corner and a Harley Davidson went by and he got so disoriented, he almost got hit by a car because he was standing on the curb, and a person had to help him because he got disoriented when he heard the loud motor on the motorcycle, and it triggered this dizziness. So pressure and loud noise can make you have this disorientation in one ear or the other. That's called semicircular canal dehiscence or superior canal dehiscence. All right. Now, we are going to talk about diagnosing vertigo, treatment options, and how can you cope with vertigo if you have to live with it. All righty. So, what's the definition? The definition and some symptoms for vertigo. First of all, you have to understand vertigo is characterized by a false sensation of spinning or movement of objects around you, like the floor is moving when you look down, often leading to being disoriented. So there has to be some false movement. We all know that the walls are not moving, the floor is not moving, the table that you look at isn't moving. If that's happening, or you feel like you're spinning, like you're at Six Flags or Disney World, and or one of those amusement parks, and you didn't pay, then that is true vertigo. Common symptoms of vertigo: it can feel like you're dizzy, room spinning, balance issues. Of course, if you can't get oriented, you think you're moving all over, you have no spatial awareness, you can't figure out where you're at, where your body parts are to get oriented. So you feel like you're spinning, just like that picture that you see here in this video or on this slide, this ice skater spinning around, spinning around, spinning around. It can create nausea, sometimes vomiting. It can impact your life. I remember I had dizziness after getting a particular shot, and I'm not going to talk about which shot it was, but I took a shot and I had become so dizzy, I could not figure out where I was standing. I ended up, there's a post in the middle of my home that is a load-bearing post. It has to be there. Don't like it, but it has to be there. And I thought that I was walking away from it, but I walked smack dab into it and it knocked me to the ground because I was so dizzy. I thought I was on one side of that pole, but I was right in front of it and it just knocked me down. That's how this type of dizziness can be. Does it affect your life? Well, of course it affects your life because you don't know where you're at. Great. Now we're going to talk about the types of vertigo. You have peripheral vertigo or central vertigo. This is why I was saying it's kind of like you can't just come into the office and say, I have vertigo or I have dizziness. We have to figure out what type do you have? Like I was explaining to you about the jeans. What type of jeans are you wearing? What is going on? Well, we want to know, is it peripheral? If it's peripheral, periphery means anything on the body that hangs off of it. Our ears hang off the central core of the body. Our arms, our hands hang off the central core of the body. Our hands, feet, and legs hang off the central core of the body. Therefore, they are peripheral organs. The ear is a peripheral organ because it literally hangs off the side of your head. Now, central vertigo. Central vertigo has to do with the brain or the spinal cord. The brain or the spinal cord. So if you have something going on like a brain tumor, that would have to do with the central nervous system. If you have something going on with the optic nerve, which is the nerve for your eye, that comes off of the brain. So that is something that has to do with central vertigo. If you have neck pain, severe arthritis of the neck, a herniated disc that's herniated forward into the area where if you look at this brain and then you will see that yellow line is the spinal cord. And off of that, you'll see the spinous processes. In front of that yellow line, you'll see some little squares. Those little squares are vertebral bones. Vertebral bones. Between each vertebral bone is a blue object that is a disc. So you have discs. Those discs can herniate backwards and put pressure on that yellow organ. And when it does, it then slows down the electrical impulse through the spinal cord, causing what? Dizziness. Okay, so these are the two types. There's peripheral and central. It is important to know because this is how we figure out how do we treat you. Because doing something for the crystals in the inner ear is not going to help with a herniated disc in the neck if it's a central problem. Doing something to reset crystals is not going to help if you have a large brain tumor that is putting pressure on the vestibular nerve. That's not going to help you. All right, let's go to our next slide. So what are some of the common disorders? We talked about it in the agenda. And so now I'm going to get into the real nitty gritty of it. Benign paroxysmal positional vertigo, BPPV. That does have to do with the crystals in the inner ear. They will get caught up in the loops of the cochlea. The cochlea. We talked about that being in the inner ear. So yes, that is an inner ear problem. Vestibular neuritis, severe cold symptoms. It causes inflammation of the vestibular nerve if it's vestibular neuritis, leading to sudden and severe vertigo. Sometimes, now, what's the difference between vestibular neuritis versus labyrinthitis. Now, this is kind of deep, but my audience is really intelligent and you're able to track with me. And so I make things easy so you can understand what we're thinking or what we're looking for. So if we want to know if something is vestibular neuritis, this is why a lot of people get upset with the otolaryngologist, because we want hearing test. We use the hearing test in the same manner that a cardiologist uses an EKG. If you don't get upset because the cardiologist asks you to disrobe, take the bra off so they can put the leads on and do a EKG, or put gel on the chest and do an echocardiogram, if you're not going to get upset with them, please don't get upset with otolaryngologists and neuro-otologists. Please don't get upset with us, because we use the audiogram. We use the audiogram to tell us how best to help you. If we have an audiogram and there is no hearing loss, but you had severe sickness, it lasted for a few days, you ran a fever, you were sick enough to be vomiting, it was horrible. You can remember the day that it occurred. You were crawling on all fours. At that point in time, we know it's vestibular neuritis. After we look at the EKG, not the EKG, I'm sorry, the audiogram, and we tell you don't have hearing loss. However, it's labyrinthitis if you have hearing loss. So that way we can tell what it is that you have. Meniere's disease, we need the audiogram, because with vestibular neuritis, no hearing loss. Labyrinthitis, there is hearing loss. Most times it's in one ear or the other. That helps us. Second thing that we need to know is how much hearing loss. And then we want to know, is that hearing loss low frequency hearing loss, or is it high frequency hearing loss? Most low frequency hearing loss that lasts for 30 minutes with dizziness, because there's a triad. What's a triad? 3 different key symptoms that occur with Meniere's disease. That triad is vertigo or dizziness, room spinning, hearing loss, usually high frequency hearing loss. I digress. I'm sorry. Usually low frequency hearing loss. So like 250, 500, 1K, 1000 hertz. In that area, your hearing loss is noted in one ear or the other. It can happen in both ears, but it's kind of rare. So you have that triad of dizziness, hearing loss, and the third thing that occurs is ringing in the ear, or that tinnitus, high frequency squeak, or like wrinkling of paper. Or, so for those of you that are in my age category, you'll figure it out. When you used to put on that 45 or that 33, when you would first put it on to hear your favorite record, hold on, I'm coming, hold on. That crinkling noise may be what you hear, almost like a speaker busted or breaking, okay? The next thing is the semicircular canal, which you will have, that occurs when there's a hole in the bony covering of the superior canal of the cochlea. Rare condition, but it can happen. Let's move on. So, what are some other causes? What other causes can occur with dizziness? Well, there are different causes, and there are 5 common things that can occur. We just talked about those, but then there's some things I want to talk about, stuff that has nothing to do with the ear. Let's go over those. Here's some brain issues that can cause dizziness. Migraine headaches. You may have migraines that started out and they were just, you were bothered by light or sound. When you worked on your computer, you'd get a headache, unilateral headache that would maybe make you nauseated. Sometimes it caused you to vomit if it was a pain scale of over 7, over 6. Those things migraines can cause. Now, your migraine can change and then you can have dizziness with it. So that's called a vertiginous migraine. So you can have a vertiginous migraine. You'll get dizzy spells first, then within 20, 30 minutes, you start getting a headache really bad. Light and sound affect you. And those kind of headaches are better dealt with certain types of medicines. However, that's not ENT related. A neurologist or your regular doctor can help you with those. Strokes. Strokes can cause dizziness. Now, you can have a hemorrhagic stroke. That's where a blood vessel has broken and it bleeds, making you to be anemic suddenly and changing your volume in your blood. And now all of a sudden, because you have such a leak, you start getting dizzy. Or you could have a blockage. If there's a blockage, now there's a decrease of oxygen to certain parts of the brain. And if there's a decrease in oxygen to the vestibular system, definitely you will have dizziness. Abnormal growths or tumors in the brain, that can cause dizziness, especially if the tumor or growth is compressing the vestibular or balance nerve. Now, here's some other things that can occur. We talked about C-spine arthritis or cervical spine issues. We talked about that already. If you have anemia, severe anemia, you could have a GI bleed. I've had patients that come to me and just because I felt like, really digging into what was going on because I knew it wasn't the ear, but I said, well, let me see if I can help this person because it's been going on for so long and they're frustrated. And so it was kind of like a good episode of House. And I figured out, so I just asked them, hey, are you having dark colored stools, black or bloody stools? Well, sure enough, it was, and not eating, not having greens and or taking iron pills or anything. Come to find out and get a CBC, and the male was anemic. Men are not normally anemic. The reason why it wasn't a GI bleed, but he was bleeding in the bladder because he had bladder cancer. So there's always different reasons for dizziness. Dehydration. Dehydration is another thing. So I find a lot of men, older men that go out, play golf in the hot sun in the summer, don't drink enough water, don't drink any Gatorade or All Sport or one of those smart waters or something like that. And then they end up being dehydrated because they also go in after golfing and eat a bunch of chips and pretzels and salty stuff and have a couple of brews, and then they become dehydrated. Their ear can sometimes lose the fluid that it needs because their body's so dehydrated, and they can become dizzy. Cancers, we talked about. Heart arrhythmias can cause you to be dizzy. Certain medications can cause you to be dizzy. There's also anxiety. Panic attacks can cause you to feel dizzy. Then there's a whole different sensation called the postural, persistent, perceptual dizziness. And that can, if you tend to look at patterns on the floor, if you're riding in a car and it bothers you when you look outside and you see things going past the window, then and then you feel dizzy all of a sudden and feel anxious like you're going to fall and you're already sitting down, that's not normal. And so that would have to do with being having that postural issue. It is rare, doesn't happen a lot, and can cause people a lot of problems. All right. Now, the best thing to do is get a really good history on a patient. Dizzy patients take a little while to take care of because you want to dig in and find out, is it one of those 5 things? Most providers, once they find out it's not an ear, then they send you back to your PCP for them to figure it out. Me, I like to feel like I'm in an episode of House and try to help figure out what it is. If it's one of these other issues, I'll dig into it as best I can and then get help either from cardiology or neurology. Importance of getting the history is because it helps you to determine which way you're going to treat the patient. So, a hearing test, it's important. A hearing test, it's important. A hearing test is really important. Oh, did you know that a hearing test is really important when you have dizziness for the otolaryngologist to help determine what's wrong with you? Oh, let me tell you this. You should get a hearing test. I know you can hear. I know you think you can hear. I know you don't feel like you have a problem with your hearing, but you don't need it. I need it. You don't need it. The otolaryngologist needs it. You may not need it, but the neuro-otologist needs it. Thanks. Get a hearing test. All right, so imaging studies. This is another reason we need the hearing test, because we need to find out, is it conductive hearing loss or is it sensory neural hearing loss that you have? If it's conductive hearing loss, then we know that we need to probably get a CT scan. What if you have semicircular canal dehiscence or the superior canal dehiscence? The only way you're going to find that is to be able to look at a specific type of CT scan. I'm telling you this because it helps you to understand what we're thinking so that you know why. Because a lot of times you, as patients, want to help us, but you're not helping us when you fight us because you don't want to get a hearing test, when you fight us because you want an MRI, and an MRI is not going to show you what is going on with the cochlea at that time. An MRI of an area called the IACs, that's where the internal canal, that's where the vestibular nerve and the cochlear nerve come in through this little tunnel and go from the brain into the cochlea. Well, we want to look at that area to make sure that there's no tumor, growth, lump, bump, mass, bleeding, or something's going on with the cochlea where it's atrophied or something like that, abnormal. That's when you want an MRI. Because now, sometimes you can't get an MRI because a person has a pacemaker or something like that, or they were in a war and they got shot and you can't do that because they have a bullet in them. Then you would have to use a CT scan, but you have to get a special type of CT scan, okay? You need to know there's a particular balance test. I don't use it except rare occasions if we just really can't figure it out, and it's called a vestibular nystagmogram. Very rare that you get them, but they help to determine whether it's a peripheral or a central problem that the person is having dizziness. If we can't figure that out clinically, most times you can. Okay, I just talked about testing, and that's to identify what type of vertigo it is. We want to differentiate different conditions, which we talked about already, and the health of your inner ear. Now, real important, and then I know this one is a little long this time, but it was a lot of stuff in here. Medications and therapies for dizziness. Medications for dizziness, antihistamines such as meclizine. They use that but it can cause dizziness. I don't like to use that for a long period of time. It does help with your symptoms for a short period of time, but I don't like to do it for a long period of time, more than like a month, because it starts to affect the nerve and blunt the nerve so that you just don't, it makes your vestibular or your spatial awareness weaker, and it's hard for you to get that back. Now, scopolamine, that's an anticholinergic medicine, and you can use that as a patch. It's a motion sickness patch. I kind of like that a little bit more than the meclizine because of its mechanism of action, and it does help you with the motion sickness and the dizziness. Medication such as phenergan or compazine, that helps with nausea. Physical therapy or vestibular rehab. Here, this is important. I'm going to show you a little video. Like I said, this one is a little long. This episode is a little bit longer, but I want to show you some videos so that you can understand what nystagmus looks like.
To that left side. And you'll look for the involuntary eye movements in this position.
Let me move this back because this is important. If you see this on someone, I want you to understand what's going on.
Hi, my name is Brian Prell. I'm a physical therapist and I specialize in the treatment of vestibular imbalance disorders. Today we're going to look at involuntary eye movements called nystagmus. This information can be used to determine what type of vertigo you actually have. Now, in looking at nystagmus, an easy way to test this is to have your patient sitting straight up. What you want to do is you want to provide a visual cue. We'll actually start, you can use your hand or you can use a piece of paper. And what you'll want to do is we'll start with the right side. Put your hand or the paper on the right side and you'll ask the patient to turn their eyes to that left side. And you'll look for the involuntary eye movements in this position. After that, you'll switch to the right side and you'll have the patient move their eyes to the right. And again, looking for those involuntary eye movements. The first type of involuntary movement you might see is the eyes shaking from side to side, moving faster to one side than to the other when looking right and left. Similar to the previous type, you may also notice an eye movement that moves side to side, but at the same speed when looking left and right. Another type of eye movement to look out for is any up or down eye movement. Finally, you might see a type of eye movement in which the eyes just seem to rotate or turn in place.
So I want to quickly put another video on. And this video is going to talk to you about treatment with the Dix-Hall-Pike versus Epley. So this is so that you can understand what we're doing to you and why.
Hi there, my name's Andrew. I'm one of the final year medical students. Could I just confirm your name and date of birth, please?
Sure, it's James, 13th of December 1989.
Great. James, I know you've been having some dizziness recently. I'd like to perform a special test called the Dix-Hall-Pike maneuver. You'll start sat up on the couch. I'll then turn your head to one side and we'll lower you down quickly. I'd like you to try and keep your eyes open at all times. Would that be okay?
Yeah, that's fine.
Do you have any pain in your neck, or have you had recent surgery on your neck?
No.
Great, we'll begin. James, I'd now like you to turn around and bring your legs onto the bed.
If your provider doesn't ask you about your neck, they want to start that Dix-Hall-Pike, be sure and let them know if they don't ask. You saw he asked in this video.
I'm going to hold your head in my hands and turn your head to one side. And I'm now going to lower you down quickly.
Notice the head is below the bed. We do this to both sides. And if it's positive, meaning the eyes are bouncing like we showed
I'm
you
now
in
going to
this
turn your head to
video,
the left-hand side.
we do this, the Epley maneuver. This is
Now, James, in your own time, I'd like you to turn onto your left-hand side.
You'll feel dizzy if it's positive, and like you're going to
James,
fall.
if you would now swing your legs over the side of the bed and slowly sit up. That's the end of the procedure. Thank you very much.
All right. So those the Epley maneuver and the Dix-Hall-Pike test, and helps to find out about the nystagmus and what's happening and whether we need to do the test or not. That's what those videos were for. There's a difference if you go to physical therapy because of benign positional vertigo versus the being off balance from Meniere's, or because you had a long-term injury from the vestibular neuritis labyrinthitis. That you need vestibular rehab. Vestibular rehab is the resetting of your body's proprioception, or your body's ability to know where the other body parts are. That is so that you can walk on uneven surfaces, you can turn quickly, move quickly, and you won't feel like you're going to fall over. That's the difference for when you go to physical therapy for vestibular rehab versus the canalith repositioning. Canalith repositioning is not going to help you with your balance if you don't have that as a problem. That's why we have to make a true diagnosis. Physical therapy helps with your balance, helps with motion desensitization, and that's where you can see on this video, in this picture, where there's someone standing on one leg. A lot of people, and sometimes seniors, just because you have your AARP card doesn't mean that you can't do exercises. Yes, you can, and those things can help. You don't have to be handicapped or disabled. You can get some of your body's ability to be strengthened and to have some stability with coordination. It's important that you do that. So you may want to go ahead and do the physical therapy. It's going to be helpful. I have a lot of people that fight me on it. They don't want to do it because they just don't feel like it's going to help, but it does. There are some rare things that can happen where you would need to have some surgical intervention because your dizziness is so bad off, but I didn't want to talk about those too deeply. It's a whole separate issue, but a neuro-otologist is who you need to see. A neuro or a nerve otologist, because it's from either an acoustic neuroma or a growth on the nerve, or they have to, Meniere's is so bad off that they have to just deaden the nerve with a medication so that you don't have the problem of feeling dizzy and having the ringing in the ears. Okay? Stay hydrated. Avoid sudden movements while you're healing. Avoid excessive salt and caffeine diets if you have the Meniere's, and if you need to, use an assistive device until you get your balance back. Otherwise, you can fall and injure yourself. There are support groups out there. Now, most offices or separate offices, they don't know about the resources that they are, so you'd have to call a hospital and figure that part of it out. Now, in conclusion, Get an understanding. It's important that you help your doctor to get a full understanding of what may be going on with you in order to manage your problem appropriately. We need to get an accurate diagnosis to be able to treat you appropriately, to be able to send you to physical therapy, asking them for the right thing to do for you, not canalith testing if we have to help you with your vestibular system. All right. Treatment options we need. Oh, did I tell you you need to get an audio when you come to? Yeah. Okay. For dizziness. Living with the issue. We can help you if you do the physical therapy. Sometimes you have to go through and have some surgical interventions. That is very, 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 very rare. But hopefully there was a lot of information that you got out of here. You can always go back on my YouTube channel, Body, the letter N Balance 25. You can go to that and go over the slides to help you. Hopefully, your horizons have been enlightening.